Good afternoon and welcome. I'm Tom Moore, Media Relations Director with University of Iowa Healthcare. We're glad you have tuned in today to learn about pelvic health conditions and what you can do about them. Before we begin, I have a couple of housekeeping items. We invite you to use the Submit a Question box to ask our presenter a question anytime during the webinar. Check our website, www.medicine.uiowa.edu/community for upcoming educational programs across the state of Iowa for children and adults. Now let's meet our presenter. Catherine Bradley, MD, MSCE, is a professor of obstetrics and gynecology. Now let's begin our presentation.
Hi, my name is Kate Bradley. I'm a urogynecologist here at University of Iowa, and I'm excited to talk a little bit about pelvic floor health. We call this seminar Half of All Women because while a lot of the pelvic floor problems that women experience, like embarrassing bladder accidents or vaginal bulging, are common, we found that only half of women who have these problems or symptoms actually talk to a healthcare provider about it. They can be very embarrassing. They're not something that some women feel comfortable talking to family or friends about. So we're trying to get the word out and educate women that these are problems that we can treat, and hope you will learn something today that may help you change some behaviors that could prevent some of these issues from occurring. So I'm a urogynecologist, and that is a term that's not used very much. I'm an OBGYN doctor who specialized in the care of women with pelvic floor dysfunction or disorders. So I did extra training after my OBGYN training in order to take care of women who have these pelvic floor problems. And these include bladder problems like urinary incontinence, and I'm going to talk about that a lot today. It includes pelvic organ prolapse problems and some bowel or defecation problems. So I'm really going to focus on urinary incontinence and pelvic organ prolapse. These are probably two of the most common conditions, but there are several more, and I'm not trying to ignore those. We just can't cover everything in 1 hour. The pelvic floor is the structure that really helps support our pelvic organs. It includes muscles, ligaments, connective tissue, and nerves. And by supporting these organs, it also makes sure that they function correctly. So we're talking about the function of the bladder and the rectum. We know that the pelvic floor can be damaged by childbirth, by repeated lifting or straining, and in some cases can be damaged or weakened by chronic disease or surgery. I have a picture here. This is a diagram of a woman who's been kind of drawn in half, and on the, I think my mouse will work here, on the right side here is her abdominal wall. Here's her back and buttocks, and you can see the pelvic organs are contained here. And this structure here, and I think I color it like this. This is the main pelvic floor muscles. They make up the bulk of the pelvic floor. They're the most important structure. You can see how they kind of act as a sling or a support structure for these organs in the pelvis. And as humans, we are upright much of the time. We're walking and moving and sitting, and all that time gravity is kind of pushing these organs down into the base of our pelvis, so this pelvic floor is really important. And why focus on these problems? Well, as I said before, they're really common. So we know that up to 1/3 of all women may have some of these symptoms. When we look at older women, so really focusing on women 75, 80 or older, almost 1/2 report some of these symptoms or problems. These pelvic floor problems occur when the pelvic organs are not functioning correctly, often because they're not supported properly. And as I said, these are underreported, embarrassing conditions that are sometimes difficult to talk about. And I think luckily women are feeling more empowered recently about asking their healthcare providers about this, or about talking about their symptoms or conditions with family or their partners or spouses. And of course we would encourage that. And As urogynecologists, we talk about these conditions every day, and so we're not embarrassed to talk about them. And hopefully people feel very comfortable coming to us and learning more about what's going on. They're also really important because we know that pelvic floor disorders worsen women's quality of life. Most women are not going to have serious health problems because of prolapse or incontinence, although sometimes they can be serious. But what happens is these disorders impact our quality of life. They prevent us from doing things that we want to do. They prevent us from being social and interacting with other people if we're embarrassed about these issues. And really important to understand that almost always these are treatable conditions. So we sometimes laugh when women have to use the bathroom a lot, and we think that older or elderly women may have to put up with some of these problems. But we don't believe that pelvic floor disorders are a normal part of aging. These are not inevitable consequences of childbirth difficulties or of menopause. And I would encourage you to take action if you have some of these symptoms. Ask your doctor about them, discuss your symptoms, learn more about them and your risk factors, and we will talk about some of this in a bit. If you're bothered by your symptoms, certainly ask your healthcare provider about it and get some tests or screening if that's needed and learn what can be done. I'm going to talk much at the end of this talk about what we can do to potentially prevent some of these from happening. And there's really no reason not to do that now. Why not make things better now and have better pelvic health? So I'm going to focus on two of the more common problems: pelvic organ prolapse, which we probably don't know as much about, and urinary incontinence, which is probably the most common condition that we see. These are important because they're common. We know that women up to the age of 80 have an 11% chance, so about 1 in 10 women may need to have surgery because of urine incontinence or pelvic organ prolapse. So that's very common. And then that's just the tip of the iceberg. We know that many more women have these problems, but maybe don't seek surgery, or they may have milder symptoms that are bothersome, but not to the extent that they would choose surgery. So we want to find these women and make sure they know that they can seek treatment. So for the rest of the seminar today, I'm going to talk specifically about some definitions. I'm going to review the symptoms that women may experience if they have these pelvic floor problems. We'll talk a little bit about why they may be happening. And then if you were to seek treatment, what does that mean? What would the healthcare provider or doctor or specialist who saw you do when you first went in to talk about having urinary incontinence or prolapse symptoms? What are the treatments that are out there? And then finally, we'll focus on some behavioral changes that almost anyone could make that may help prevent some of these problems from occurring at all. Or maybe if you have very mild symptoms, these behavioral changes could help prevent those from progressing and becoming more bothersome where other treatments would be necessary. So we're going to talk about pelvic organ prolapse first. Pelvic organ prolapse occurs when the supportive tissues around the vaginal walls and uterus weaken, which allows the pelvic organs to drop. Women experience a bulge or protrusion in the vagina or even protruding through the vaginal opening if they have prolapse. Although mild types of prolapse may not cause any symptoms, and a woman might be just going for an annual checkup to their gynecologist or primary care doctor, and they may be told after a pelvic exam that they have milder types of prolapse. The slide here lists a few of the types of prolapse that we see, and when we do an evaluation, our job is to figure out what type of prolapse is happening. Not all prolapse is the same, and we have a lot of complex kind of medical terms for these problems that have actually been around for over 100 years. So I've listed a few of the common ones here. Some women have a Sistah Seal. This is when the front wall of the vagina sags downward or outward, and this allows the bladder to kind of drop from its normal position and may impact bladder function. A lot of women will say or hear, that my bladder has dropped, or I have a dropped bladder. And that's a little confusing because really it's not the bladder's problem. The bladder is okay, but the support around the bladder has weakened or been damaged, allowing the bladder to kind of change position, and that may affect bladder function. So we call that a Sistah Seal, and that's probably the most common type of prolapse that we see. Now, you can also have something called a Rectocele, and that just is similar, but it means the back wall of the vagina is involved. And because the rectum sits behind the vagina, that allows the rectum to bulge forward and may impact bowel functions or bowel movements. And then some women have uterine prolapse, and this occurs if the supports around the uterus or cervix weaken, allowing the uterus to drop down, and sometimes the cervix then will bulge into the lower vagina or even protrude through the vaginal opening. So prolapse may occur because we think these support structures have been damaged or weakened, and this may happen after vaginal birth. That's one of the main risk factors for pelvic floor problems, and particularly prolapse. It happens a little more often when a woman has delivered a very large baby, meaning 9 pounds or more. It happens after more difficult labors and particularly more difficult deliveries, potentially where a lot of pushing was required, or a delivery that was difficult and maybe needed assistance from the healthcare provider, whether an obstetrician or another doctor or midwife, to help deliver the baby, say with a vacuum or with forceps. Prolapse is also more common with aging, and some women who haven't had these other risk factors still may develop prolapse. And then the last thing we think about is that any condition that may increase the pressure in the abdomen over time may increase the risk, and this can include obesity, it can include chronic coughing or straining, and we'll talk about some of those things later on. And finally, prolapse can run in the family. So there are some women who have sisters or mothers who have had prolapse or prolapse surgery, and they may be at increased risk. And usually more than one of these causes is present. So a woman may have an increased genetic risk, and then perhaps she has a lot of straining because of chronic constipation, or she had a very difficult delivery that caused some damage. And we can't always pinpoint the particular cause in each woman, but these things may combine to increase the risk for different women. Here are some of the symptoms that can be associated with prolapse. So as organs start to prolapse, women may feel heaviness or pressure in the pelvis that can be uncomfortable, a pulling sensation. Prolapse is not usually painful, but it can be achy and uncomfortable, particularly at the end of the day when the woman's been on her feet for a long time or if she's been doing a lot of lifting. The most specific symptom to prolapse, and this usually occurs as prolapse becomes kind of more moderate or severe, is actually seeing or feeling a bulge at the vaginal opening. And this is the vaginal wall prolapsing down or potentially the cervix. Some prolapse may result in lower back pain. Prolapse may cause painful sex or difficulty with sex, although not always. And then some types of prolapse are associated with bladder symptoms. Women may have some frequent urination or frequency. They may have urgent sensations to urinate, other bladder control problems like incontinence. They may have difficulty emptying the bladder as prolapse becomes more significant. And similarly, if the prolapse involves the back wall of the vagina, closer to the rectum, they may start having difficulty with bowel movements. So I'm going to switch gears now and cover some of the same information for urinary incontinence. Urinary incontinence is another very common pelvic floor disorder. It occurs when urine leaks out before a woman can get to the toilet to empty her bladder normally, or just leaks during normal activities when she's not planning for that to happen. There are also many possible reasons why a woman may have urine leakage, and these in some cases are similar to why prolapse might develop, and in other cases they're unique to incontinence. So urinary incontinence is more common after pregnancy and childbirth, particularly more difficult childbirth. It's more common with increasing age. It seems to be related in some women due to less estrogen occurring after the menopause. It occurs when muscles, those pelvic floor muscles, are weakened. Sometimes when there's an obstruction to urinary outflow, for instance, prolapse or other types of problems, that may actually increase urine leakage or symptoms. And then there's also issues when nerves that control the bladder are damaged, and this could be related to difficult childbirth, which can in itself might have damage some nerves and weakened tissues, but it also can occur when a woman has a neurologic problem or another health problem that impacts the nerves to the bladder. For instance, multiple sclerosis or a stroke, Alzheimer's dementia, or Parkinson's disease, or spinal cord problems. Those are all neurologic problems, so other health problems that can impact bladder function. Diabetes is another important one that can impact bladder function both through maybe some nerve damage to the bladder or for other reasons related to diabetes. And finally, there are just physical problems with aging or a genetic risk, a little bit like prolapse. So some women tell me that their mother or their sisters had a lot of problems with urinary incontinence, and now they're coming to see me as well. So here's a list of some of the symptoms of different types of urinary leakage, and this is very important when I see a woman in evaluation for urine leakage problems, trying to figure out which type of symptoms she really has most often. And sometimes people have more than one of these symptoms. So some urine leakage may occur during physical activity or movements like coughing, sneezing, or exercise, or lifting is another common time leakage can occur. Some urine may leak with a sense of urgency because the woman suddenly feels like she needs to get to the bathroom and maybe she can't make it in time, or there was just no warning and suddenly she feels urgency and is having urine leakage. There's other types of leakage. There's leakage that happens or incontinence that happens because of a patient having difficulty getting to the toilet in time. So maybe their bladder would be okay if they were able to get to the bathroom more quickly, but because of difficulty with walking or difficulty with obstacles in the way or problems thinking or communicating, she may have incontinence. And then some urine incontinence can be temporary. So some women may develop more incontinence symptoms if they have a bladder infection or a UTI, or they may have a terrible cold that causes severe coughing, and that makes them leak, where they wouldn't leak potentially with kind of normal day-to-day coughing. So here are a few of the types of urinary incontinence, and our job as a provider evaluating a woman who has urine leakage to figure out why this is happening. Not all urine leakage is the same. And I'm going to talk a little bit about stress and urgency incontinence in particular. These are the most common types of leakage. Overactive bladder as well, very similar to urgency incontinence. And then overflow incontinence is less common. This happens when the bladder is not emptying well and may leak just because it's so full. So first, stress incontinence is the type of leakage we see most often in younger or kind of middle-aged women when they present with new symptoms. It can occur after childbirth. This is leakage that happens with physical activity, so coughing, sneezing, lifting, and exercise. Some women, it happens just when they really strenuously exercise. For instance, a strenuous aerobics type class, or weightlifting, or jumping on a trampoline. I often hear that because that puts a lot of pressure on the pelvic floor. But as stress incontinence becomes more impactful, it may happen with even less strenuous activities like lifting or picking up your toddler, or possibly when it's quite severe, even just walking across the room might cause stress incontinence. The next type is urgency incontinence. And again, these are really different types of problems. Urgency incontinence is leakage with urgency, that sudden sensation that I have to get to the toilet, or I might have an accident or leak a little bit of urine before I can kind of get there. And this is the most common type of incontinence that I see in middle-aged women and older-aged women, although I certainly see it sometimes in younger women as well. Urgency incontinence is often part of a larger condition called overactive bladder. And this is caused by, or the symptoms that make up overactive bladder is the frequent need to urinate. So they complain of we call that frequency, daytime frequency, or having to wake up at night often to urinate, which we call nocturia. They might get sudden, unexpected needs to urinate, and we call that sensation actually urgency. It can be quite uncomfortable or a problem if the bathroom's not close at hand, because then a leakage or accident may happen. Many women have urgency incontinence and overactive bladder, but other women have overactive bladder with the frequency and urgency symptoms, but they don't actually have incontinence. About half women may have a lot of frequency or urgency, which in itself can be really bothersome, but they don't leak. And that's still considered overactive bladder and a pelvic floor problem that we care for. And women who have overactive bladder may see the world this way, in that it can really make it difficult to go places if people are constantly concerned about where the bathroom is. So, we make a joke about this, but it clearly is a major problem in terms of their quality of life. Some women tell me that they know where every bathroom is in their town because they never know when they're going to have to pull over and find the closest bathroom. We actually call that toilet mapping, and it's a problem that happens with overactive bladder and urgency incontinence primarily. So if you or a woman chooses to be seen by a provider for pelvic floor problems or symptoms, what does that mean? What would you experience at a new patient visit? First, we would do a good history. We would want to find out all about the symptoms that are happening. For instance, if you were complaining about urinary incontinence, we want to know just what I was talking about. When does that happen? What other symptoms are going on in the bladder? Have you had prior treatment for that? And then what are your other medical problems or health history? What surgeries have you had in the past? What medications are you taking? What are your allergies? These things are all very important for us to understand, and we have to do this kind of extensive history the first time we see a patient. We then need to do an examination, and that would include a pelvic examination in women who have these problems. We would do a test of the urine. We'd want to make sure there is no blood in the urine. That's kind of a warning sign for more concerning problems that would have to be evaluated. We don't see that too often, but it's something we always check for. We would want to rule out the presence of infection. Once in a while, women, particularly older women, I think, have bacteria in the urine that could be contributing to some of these symptoms, even though they don't have kind of typical bladder or UTI infection symptoms like pain or burning with urination. So we always look at the urine with a urinalysis to make sure there's not infection present. We often ask our patients to do a bladder diary. I even ask new patients to do that and bring that with them to the new visit, because we learn so much about their voiding symptoms and urine symptoms from that diary. And I'm going to just show you an example here of what that might look like. So here's a diary where that's pretty complicated, and some diaries are much simpler. You may just be asked to kind of write down the times that you went to use the bathroom and urinate, or write down if or when you leaked and what was causing that. In this diary, this person was actually asked to record everything that they drank. So all of their fluid intake, how much, they were measuring it here. I noticed although the diary says ounces, they're writing this down in milliliters or cc's. Doesn't really matter how you keep track of it if you're measuring volumes, as long as you do one or the other. So they're writing down how many drinks they had, what they were, how much they drank. They're writing down all the different times they went to the bathroom to urinate, and they actually measured how much they urinated each time. And then they wrote down when they had a leak. So I think you can see my mouse here, the arrow. This woman on this day leaked 3 times, where she wrote a yes or a Y. And then this first one happened when she sneezed, the second one when she lifted a heavy bag of something, and then while jogging. So this bladder diary is very suspicious for stress urinary incontinence, urine leakage that's happening with physical activities. When I get back to some behavior modifications, I'm going to focus in on types of fluid and amount of fluid, because this may be impacting symptoms too. And so the diary is helpful for us in that way. So we talked about what you might experience. Usually an initial office visit doesn't involve any more invasive tests. Those are usually reserved for people with more complicated problems, or people who start treatment and they don't respond. Then it may be appropriate to do more tests. Some women who have more complex problems because they say they have a neurologic condition that I mentioned, like multiple sclerosis. Patients who have that kind of health history, or who have had prior surgery or treatment that has failed, it may be reasonable to do other tests earlier in their evaluation. But on the average patient, we can start treatments after a basic office visit and urine test. And I think I forgot to mention, I'm going to go back one slide, if I can do that. I forgot to mention bladder emptying. So in my clinic, we check to see that all the patients who are complaining of urine incontinence are actually emptying their bladder after they urinate. So once in a while, women think that they've emptied, and they don't have a sensation that they haven't, but then when we check, they actually have we call it an elevated residual, or they have urine left in the bladder. Everybody leaves a little bit of urine in their bladder. An ounce or two is actually very normal after urinating. But if a lot of urine is left, that's going to really change how we evaluate that patient. As I said, that's not as common, but it's something that we check. Now, not every woman may need that with the very first visit, but it's something that is often done. So finally, I want to talk a little bit about treatment and some of the preventive things that you can do. And this is a really important slide because I think it's important to understand that women have choices. These are problems that cause quality of life issues. And every woman knows, how much they're bothered by their symptoms. And surprisingly, that really varies. So I see some women who have urine leakage and they don't feel like they're that bothered. They can deal with that somehow, and they have other things that are a higher priority for them. And then I see some women who have urine leakage that seems maybe lesser to me, but she is really bothered by those symptoms, and so it's very appropriate to start doing treatment for that. So each patient, I think, has to choose what treatment may be best for them, and if they want treatment. So it's important that for the majority of women, you could elect not to have treatment and maybe just to learn more about what's going on. But if treatment is desired, we have behavioral treatments, we have medications, and finally surgery. And so there's a wide variety of treatment options. And of course, we usually start with the easier things like behavioral changes or potentially medications. And we usually reserve surgery for people who have tried those conservative things or people who have much more severe symptoms. But each, I think, treatment plan is different. Each patient is different. So I'm going to talk a little bit about the treatments that are out there, and then we'll talk about prevention, and then you'll get a chance to ask questions. So first for prolapse, and you'll see some of these treatments are the same because these disorders are related. I always remind patients when I see them for prolapse that if they're not too bothered, most of them could elect to do nothing. We call that watchful waiting because it makes us feel like we're doing something, and in a sense we are. We've done an evaluation to make sure that nothing really concerning is going on. We've educated the patient about what we think is going on and what that might mean, and then she may elect just to watch and wait and see if symptoms may get more bothersome, for instance. Sometimes we do local treatments. If the most bothersome symptoms is maybe the bulge causing irritation at the opening of the vagina, or skin irritation of the vaginal wall or the vulva, we can use things like skin barriers like zinc oxide or other types of skin protectants. We can sometimes prescribe a low-dose topical estrogen, for instance, a cream, sometimes just kind of thickening the vaginal wall or treating dryness will help relieve symptoms related to prolapse. Kegel exercises are a mainstay of treatment for pelvic floor disorders, and I'm going to discuss those a little more in detail on another slide, but these may be recommended both for prolapse or incontinence problems. And then for prolapse, our main other non-surgical treatment is called a pessary, and this is actually a device. It's a non-surgical treatment, so a device that's worn in the vagina, and we fit this to the woman. It has to be fit to make sure it's the correct shape and size. And if it's fit correctly, she can wear this pessary so that it kind of lifts up the part that's prolapsing, and that results in getting rid of the bulge if they feel that, and helping improve function of the bladder or the bowel if that's a problem. And then of course we have surgery. And usually again that's reserved for people maybe who have tried some conservative things that haven't helped or who have more bothersome or severe symptoms. So here are some treatments for stress incontinence and for urgency incontinence. Remember, these are kind of two different types of urine leakage problems, although women often have them together. We call that mixed incontinence. We usually will start talking about diet changes or fluid management that could help either of these conditions. We often recommend Kegel exercises that can be done on their own, or could be done with the help of a therapist like a physical therapist. For stress incontinence, weight loss has been shown to be effective, and that includes not a huge amount of weight loss, but even a weight loss goal of 7 or 8% of a woman's body weight can make a significant impact or improvement in urine leakage. There are pessaries for urine incontinence, stress incontinence, as well as for prolapse. I'll show you a picture of that soon. And then there are some more invasive things like injection procedures that can be done in the clinic or in the operating room, and again, surgery. And then for urgency incontinence and overactive bladder, there's the same type of attention paid to behavioral things like our diet or fluid intake. We often recommend Kegel exercises or strengthening the pelvic floor. There's some other behavioral things for urgency incontinence and overactive bladder, like bladder retraining or timed or scheduled voiding. These are things that we often talk to women about, or sometimes therapists or nurse practitioners will schedule sessions to help patients learn how to do this. For overactive bladder, we also use medicines. And then again, there are some procedures like injections or neurostimulation procedures that could be either done as an outpatient or done as kind of part of a surgical procedure. So here's my slide about Kegel exercises, and these are called Kegel exercises because a gynecologist named Arnold Kegel first described them in the 50s, actually. But we also call them pelvic floor muscle exercises because they are strengthening those pelvic floor muscles that I showed you in one of my first slides. So I'm just going to point here again on the slide. Here's a drawing of a woman's pelvis kind of cut in half. Here's the pubic bone here, and the abdominal wall would be going up here. Here's the buttocks on this side. And you can see, how close together a woman's pelvic organs are. So here's the rectum, the vaginal walls with the uterus above that, and then the bladder and the urethra, the tube that the urine comes out. And here's that sling of the pelvic floor muscles kind of going around those organs and back. And when you tighten those muscles, it pulls the kind of, I would say, the rectum, vaginal wall, and urethra together and kind of pushes them toward the pubic bone. And so in a sense, it kind of closes off or increases the pressure so that urine can't potentially leak out the urethra when we're doing this for urinary incontinence. These are the muscles that you would squeeze if you were trying to stop your urine stream or just slow it down. Many women cannot stop. But if you are urinating and then contract these muscles and the stream slows down, that suggests that you're doing it correctly. Also, the same muscles that you might contract if you were trying to prevent passing gas, you're contracting your pelvic floor muscles. If you're doing it correctly, you can't see anything move on the outside. So we're not moving our back or our abdomen really or our legs. It's just tightening around the pelvic floor. By strengthening these muscles, we hope to reduce urine leakage if we're doing it for incontinence problems, or to increase our control. If you have stress incontinence and you know that you're about to lift something heavy, you can do a technique called counter bracing where you actually contract these muscles as you're lifting, and that may prevent leakage. There are also ways to use these muscles to suppress urgency. So we recommend training the pelvic floor muscles both for stress incontinence and urgency problems. The next slide, I think, shows you what a pessary is. So some women have, a pessary is something that people don't talk about. You don't talk to unless you're really good friends, you probably might not talk to them about your pessary. But these are actually very common treatments that can be done. There's really very little risk to using a pessary, and so that's one of its benefits. It is something that has to be managed, and the great majority of my patients manage their pessaries on their own. We teach them to remove the pessary and then put it back in, and women can choose how often to wear it or how often to remove it. The first picture up here is actually a picture of a pessary that we might use for incontinence symptoms. You can see here it's been inserted in the woman. This is a drawing of a woman, again, kind of cut through the middle. Here's her pubic bone. Here's the bladder and the uterus. So this pessary is sitting at the top of the vagina and kind of holding up the uterus, and this kind of knob right here compresses the neck of the bladder so it's harder to leak urine. The pessaries down at the bottom of this slide are all for prolapse. Actually, this is an incontinence pessary too, and sometimes we use them interchangeably. But there are many different shapes and sizes of pessaries, and we use these very commonly. Okay, so I'm going to move on to what is under our control. What can we prevent? We know all of us are going to age. That's not under our control. Many women are going to choose to have pregnancy and childbirth. And while there's some things that we might change about the way we deliver babies. We are not recommending that everybody have a C-section. We know there are a lot of risks to having cesarean deliveries, particularly if you're planning to have several of them. And we unfortunately still can't predict which woman who has a difficult vaginal birth is going to have pelvic floor problems. Not everybody will, just some do. So if we knew in advance, maybe we could modify some things there. But for the most part, we're not going to be able to change having babies or getting older. Those things are kind of out of our control. So what can we control? So we can control the strength of our muscles. Almost everybody can learn to do Kegel exercises, and by doing that may strengthen their muscles. This can either treat symptoms that are already there or maybe prevent symptoms in the future. Now, some people have a lot of difficulty finding those muscles or doing a correct Kegel exercise. And when I see patients like that who are seeking treatment, I often refer them to a physical therapist. Now, it has to be a therapist who specializes in pelvic floor physical therapy. But there are many of them around, and they can really do a lot of help in terms of educating people and women about how their pelvic muscles work and how they can be strengthened. So you can control your fluid intake and habits. It's not always easy to change our habits, but those are things that are really under your control. And some of those risks that we talked about, many of those are things that we would consider modifiable, meaning the patient can change those things. Not always easy to do, I'm not saying that, but it is possible. And I think your healthcare provider can help you do that. So I think the next slide talks about some of these things that we can do to prevent pelvic floor problems, maintain our healthy pelvic floor. So one of them is avoiding the increased pressure or weight put on the pelvic floor. The first thing is to maintain a healthy weight. And obviously there are so many good reasons to do that. But here's another one. We know that urine incontinence and prolapse and other pelvic floor problems like fecal incontinence or bowel leakage, they're all more common in people who are overweight and obese. So trying to maintain a healthy weight is so important. I think avoiding constipation and straining over, everybody may have a little constipation here or there. That's probably not a big problem. But people who have had constipation for years and straining for years may be kind of weakening their pelvic floor. For the same reason, I think very repetitive heavy lifting may do the same. Now, sometimes we can't avoid that. If we have a job where we're on our feet and have to do very heavy lifting, we may not have a lot of alternatives. But realizing that if we can avoid it, kind of the repetitive heavy lifting may be something that we want to avoid. And then chronic cough. Just like chronic straining, chronic cough puts pressure on the pelvic floor. And smoking is one of the main reasons people have chronic cough. Other women may develop a cough because of lung problems or conditions or diseases. So you can seek treatment for that cough to avoid that increased pressure happening over and over on the pelvic floor. So the next set of things that you can do or change to maybe prevent some of these problems or to minimize, maybe you have just some very mild symptoms, making these changes may take care of those symptoms. So avoiding irritants to the bladder in our diet or in our fluids that we take in. We know that caffeine, carbonated beverages, and artificial sweeteners are all things that can kind of exacerbate urine symptoms and that can cause some bladder irritation. So this will increase urine frequency and urgency, may make leakage happen more often in some women. I should probably add alcohol to this list. So some people really just experience these problems after having alcohol. We want to manage our fluid intake. So the diary really helps me see how much fluid women may be drinking and what types of fluid. Overall, we usually recommend 8 to 10 cups of fluid a day. And although people often are drinking much more than that these days, perhaps to try to lose weight or for other health reasons, most people don't have to drink liters and liters of fluid a day. And if you're kind of on the edge of having a bladder problem like overactive bladder, taking in all that extra fluid means that you have to urinate that fluid or get it out of you at some point, and that's just going to exacerbate your urinary symptoms. Now, we also don't really want you to dehydrate yourself. Some women who have frequency problems stop drinking before they leave the house because they don't want to have to use a restroom somewhere. While doing this once in a while may not make a big difference, women who have kind of chronic dehydration, there's other health problems that we worry about. And if your urine is very concentrated because you're drinking very little water, that in itself may be irritating to the bladder lining, so maybe kind of defeating the purpose of reducing your frequency or urgency. Women who have a problem with nighttime waking, where they have to wake up at night to urinate or empty their bladder, may find that just reducing fluids after dinner or for a couple of hours before bedtime may help with that. And then some medications can cause urinary symptoms, and we always review medications with our new patients, and that may be something you would like to discuss with your health provider when they're recommending a medicine. Now, some of that we can't avoid. Women may need to take diuretics, or we often call them water pills, because of high blood pressure or a heart problem. Obviously, that's really important to treat. We're not going to say that you can't do that, but you may need to be aware that for several hours after taking that diuretic or water pill, you're going to have more urine frequency. And other things, there may be some medications that you could adjust, for instance, when you take them, or change to another medication that would have less effects on the bladder or bowels. And I think this is my last prevention slide. So you can see here that we talked about how some other health conditions may be related to bladder symptoms like diabetes or some of the neurologic things. Managing those health problems may reduce the amount of impact on the bladder. So diabetes is a big one. Keeping your diabetes under great control means that you're less likely to get a bladder problem, and if you have some bladder symptoms, they're going to be much better, more easily treated if your diabetes is also under control. Sleep apnea is kind of an interesting example of a condition that's happening more and more. It results in kind of a lot of snoring at night and sleepiness during the day. It's associated with being overweight, and we know that sleep apnea actually causes people to have to urinate more at night, so it can worsen urine symptoms, and treating it can help those symptoms. I added reducing stress here. I think we'd all like to reduce stress, and this may be one of the areas on this slide where we have less clear evidence from the literature. If you reduce stress, does that help our bladder? And that's one thing I'm very interested in. But we know that, at least I know from talking to patients, that they often feel that increased stress or anxiety just exacerbates some of the frequency and urgency symptoms they have in their bladder, and they may get better trying to reduce stress. And of course, the overweight and obesity problem that I mentioned, trying to prevent that or treat that or work on that may help your pelvic floor stay healthier. So this slide just shows the team here at the University of Iowa, and I am so lucky to work with a great group of people. I have one partner, Dr. Renee Genedry, is also a urogynecologist, so we both see patients here for urogynecology problems. Part of our job is to train other physicians to become urogynecologists. There are actually not enough urogynecologists for the number of women who are going to be having these problems in the future. So we train what are called fellows. They're already trained OBGYNs, and now they're getting the extra education and experience in taking care of women with pelvic floor disorders. I work with two really great nurse practitioners who have expertise in pelvic floor problems. And we work very closely with physical therapy. We have two physical therapists here at the university who have pelvic floor experience and skills, and we work very closely with them, often sharing our patients. And then finally, I have a great friend and nurse who is our primary urogynecology nurse, who I've worked with now ever since I've been here for 13 years, and we're really lucky. She does a lot of education and communication with our patients. And then this slide just shows some resources. So we actually see patients for urogynecology in 3 different places: at the university, hospital, at the Iowa River Landing, and we have an outreach clinic in the Quad Cities here in Iowa. We have a website that's there. And there are some great websites available for patients. You have to be a little careful about what you read on the internet these days, but I can definitely recommend these websites. The first one is Voices for PFD, or for pelvic floor disorders, and that's specifically for patients. There's one on overactive bladder that's called OAB Central. And then there's a helpful website at the NIH related to bowel control and problems with that, like accidental bowel leakage or fecal incontinence. And I think that you'll get an email later about the seminar today, and I believe we'll include these resources in that email, so you don't have to write it down too quickly here. And I think we're now ready to take questions. If you are interested in submitting a question, they're anonymous, and I'd be happy to try to answer them. Okay, so I've got a couple questions here, and I'm going to start with these. These are great questions. So the first one is, do you need a referral from a primary care or OBGYN provider to see a urogynecologist? And first of all, I didn't really say this clearly during my presentation, but many women can get an initial evaluation and treatment from a non-specialist. So there are many family medicine providers, internists or geriatricians, general OBGYNs in the community, general urologists in the community, and all of these healthcare providers may do an initial kind of evaluation, talk to a patient about pelvic floor problems, and even start some early treatments like Kegel exercises or a medication for overactive bladder. So you don't have to see a specialist initially. Now, if you see somebody and ask them questions about symptoms and they don't seem comfortable talking about that or offering you treatments, then I'd say ask for a referral or a recommendation, or you can refer yourself. And so the specific question is, at least in our clinic, while some insurance carriers may require a referral, we don't. So you can just call and say, I want to see a urogynecologist, and I think you can get an appointment to see one of us. So from our perspective, you don't necessarily have to have an official referral, but your insurance carrier may require that in some cases. So I have another question here. Are over-the-counter products such as Poise, Impressa effective in avoiding leakage? So Poise, which is a maker of incontinence pads, which is very helpful. Many women manage their incontinence by wearing incontinence pads, which is important. But I always, our goal is to reduce that dependence that they have on pads. But Poise also is making a newer product called Impressa, and I think this is it's like a Pessary, but it's a disposable product. I might have mentioned when I talked about using Pessaries for incontinence, there's actually a couple small studies that show that just inserting a vaginal tampon helps some women with exercise-induced incontinence. So I have some patients, maybe younger, who really just experience stress incontinence as a problem when they're trying to go running or do other exercise, and you may just try wearing a tampon and seeing if that helps. Our Pessaries are similar. They kind of push up underneath the urethra to prevent leakage. And the Impressa is a disposable, similar to a Pessary, but it's disposable. So you use it once and throw it away. And you initially, I think, buy a little fitting kit that has different sizes. So there is some evidence that these are effective. You can definitely try it. I don't think, as long as you're not hurting yourself inserting it, I don't think that you can harm yourself. And if they work for you, that's great. It's kind of a non-surgical way to manage leakage. They are specifically for stress incontinence, so they're really not made to help overactive bladder or urgency incontinence. And I've had a few patients come to see me who say, oh, this didn't work. And then when I see them in the office, I really don't think they have stress incontinence, so I'm not surprised that it didn't work. So you want to make sure that if you're interested in that, it's really for women who have urine leakage associated with coughing, sneezing, or physical activity. This is a great question. What recommendations do you have for a young woman that has not yet had children? So I would imagine a young woman who has some pelvic floor symptoms but hasn't had children yet. We almost always try to focus on very conservative treatments. So I would work on all those modifiable behaviors first. Fluid changes, avoiding the bladder irritants in the diet, timed or scheduled voiding, trying to maintain a healthy weight, trying to avoid constipation. So those are kind of the basic things. And then we might recommend a medication if it was for more urgency symptoms, or a Pessary potentially in some women. If it's for prolapse, a Pessary might work. And finally, when I see young women who have pelvic floor problems, I always encourage them to work on strengthening their pelvic floor, because I am concerned that if they have symptoms at a young age, those may worsen as they get older, since we know things tend to present more in older ages. So I feel like they're going to need their pelvic floor for a lifetime, and they want to start strengthening it now. We usually don't recommend surgical treatments for young women, although I have to say that that's not a strict rule. But often if we've done surgery for a problem like stress incontinence or and prolapse before childbirth, sometimes we would recommend that women not have a vaginal childbirth. So it really might impact later reproductive function, and so we try to avoid surgery when we can, I'd say. When I try to schedule my voiding, I then have difficulty starting to urinate and it is painful. Is that worse than going when I feel the urge? That is a difficult question. I think that could be happening for a couple of reasons. Sometimes if women get over full, it's a little harder to get urination or the stream started, and we don't want women to be that full potentially. The other thing is that if there's pain involved with urinating, then I'm concerned that maybe that's not typical overactive bladder. Maybe something else is going on, whether there's an infection. Some women have recurrent bladder infections and may not be aware at all times. Or maybe another condition is going on, something like a painful bladder condition, and we might treat that a little differently. I would say that if delaying urination causes pain like this or difficulty in initiating your stream, that may not be the best thing for you, and I'd probably recommend that you seek treatment if that continued. We have another couple questions. Do you have a website or local instructor to recommend for Kegel exercises? I don't have a particular website just for Kegel exercises, although that website, the first one on the list, the voicesforpfd.org, is about all kinds of pelvic floor disorders, and I'm pretty sure there is a section there on Kegel exercises, and I think there may be a PDF type document that you could download and print if you'd like to do that. In terms of a local instructor, I'm not sure if you mean here in Iowa City. We have a couple of physical therapists that I recommend here at the University of Iowa, and you could just, now some people need a referral for physical therapy for their insurance and others don't, but you could actually just call the University of Iowa Physical Therapy Clinic and ask about pelvic floor instruction, and they could schedule an appointment with one of those two providers. There are some other physical therapists around the state of Iowa that we work with, and if you may be able to, if you had a specific location in mind, unfortunately they're not everywhere, they're kind of spread out, but we could probably try to recommend that. Or a lot of times your family medicine doctor might be able to, a lot of times they in their own community would know who they could refer a patient to with urinary incontinence, and I think that would be a great resource for you. And then a question about pessaries. So how does a pessary device impact sexual activity? Very good question. So some types of pessaries have to be removed in order to have sexual activity, but not all. I mean, if you think about it, we have vaginal contraceptive diaphragms, which are devices that women wear in the vagina for birth control, and obviously they're meant to leave in the vagina when you're having sex. So some types of pessaries you can also leave in during sexual activities. Other types you have to remove. Most of my patients were able to teach them how to remove their pessaries, and so they may remove them before sexual activity. This is a problem. There's some type of pessaries that are difficult to remove, and then if a patient's unable to do that, they may not be appropriate for somebody who is sexually active. But often women can remove them and not have any problems with that. I get one question very frequently in my practice, and that is, what'll happen if I just ignore this problem? So a very common example would be a woman who has mild amounts of prolapse. Maybe they have a Sistah Seal, and she may not really see or feel that very often or only very rarely. Maybe she had an exam and her local OBGYN said, oh, you have a Sistah Seal. Maybe you should get that taken care of. And so I'll see that woman in my clinic, and a lot of what I do is education. I'll reassure them that I don't see anything more concerning. We'll talk about what prolapse is, what is a Sistah Seal, And then the difficult question is, will it get worse? And unfortunately, I can't tell them for sure if that's the case. But what I can say is that we don't have lots of information about how many women are going to worsen. We have a little bit of information about women with milder types of prolapse, that not everybody worsens over at least 2 to 3 years. It looks like about 10%. So a lot of women who I see may not get worse over the next 2 or 3 years. And there's not a lot of evidence to think that intervening or maybe doing surgery sooner rather than later for most women probably isn't a good thing to do, because maybe their prolapse will never get worse, and if they're really not bothered by it, you don't have to have surgery. Again, these are quality of life problems, so we really only recommend intervention when women are having bothersome symptoms and it's causing them a problem in their daily activities. So no more questions? I think that concludes our seminar, and I hope today was helpful and answered about questions that you had about pelvic floor health. Thank you very much.
Please keep an eye out for an email from us within the next 2 days, which is a program survey. You will also receive a follow-up email with information and links from today's presentations. Thank you again for attending the webinar, and we look forward to seeing you at future programs.